This patient with severe gag reflex was referred to us for endodontic treatment of tooth number 31. I'm talking severe gag reflex. He had gone to his dentist with a lot of pain associated with tooth number 31. His dentist had tried to do the root canal for him, of course couldn't do it. Had done a pulpectomy for the patient and temporized the tooth and referred the patient to us so we can sedate the patient and do the root canal for him. Patient has his gag reflex is so severe that the dentist couldn't even take intraoral x-rays and wanted us to sedate him and do a full mouth radiographs of him while he is sedated, and that's what we did. But I want you to pay attention to this very important matter. So this is the panoramic radiograph of the patient, and you can see that the patient had a big recurrent decay on the mesial of tooth number 31 right there. So that's why tooth number 31 needed a root canal, and as I said, his dentist tried to do the root canal and couldn't do it. But what I want to talk about here is that the subject is that you cannot rely on a panoramic radiograph to diagnose for decay and endo-related matters. So you can't use a panoramic X-ray for diagnostic reasons for endo. All right. So this is in general, right? This patient, well, they couldn't take intraoral radiographs because of his severe gag reflex, but I'm talking about in general. I've had many times my followers DM me with a panoramic radiograph such as this one, and they wanted me to tell them whether or not a tooth needed a root canal or not. And this is a patient, I'm talking about patients that you can actually take intraoral radiographs of. But for whatever reason, they went ahead and did a panel on them. So, and my response to them is always, why did you not take a intraoral radiograph? And they say, well, in my clinic, we don't take intraoral radiographs, we take panels. And I always tell them, panoramic radiograph is not the proper radiograph for endo-related matters. You always want to take multiple angulation periapicals and, of course, good bite wings as well. So you cannot base your diagnosis, radiographic diagnosis, on a panoramic radiograph for endodontic related matters. Okay, so now take a look. So this is obvious, right? Number 31. What's going on with tooth number 4? Previous root canal, but as you can see, panel is inconclusive. I'm not sure based on panel here whether or not this root canal is okay or it's not okay. Look at tooth number 13. Again, based on the panel, there may or may not be something going on. I don't know. Previous root canal. Look at tooth number 14. Previous root canal again. Is this something going on here? Look at tooth number 12. Is there something going on with tooth number 12? That's why, again, you cannot rely on a panoramic radiograph for endodontic purposes. And you need to take periapical radiographs. Don't use panoramic radiographs for endodontic purposes. All right, so now let's look at these teeth. Let's look at tooth number 4. As you can see, it's really inconclusive. Number 13, inconclusive. 14, maybe, maybe not. There's a periapical release. So these are the things that you cannot really pick up on a panoramic radiograph, and you need to take PAs for endodontic reasons. All right, so We sedated this patient and went ahead and took a full mouth radiograph. Now take a look. So as I mentioned, the dentist tried to do the root canal on tooth number 31. So that's cavit. So the dentist removed the decay and did a pulpectomy for him and placed cotton pellets in here and more cavit and referred the patient to us for IV sedation. And that's what we did today. So we did tooth number 31, as you can see, periapical relucency as well. All right. So now let's look at tooth number 4. Remember, on the panel, tooth number 4 had a root canal before. You can say that, you can see that, but periapical status of the tooth number 4 was inconclusive. But it's not anymore. It's not inconclusive based on the PA. As you can see, large periapical relucency associated with the tooth. On the panel, you couldn't tell. Maybe there was something, maybe there wasn't. All right, but as you can see, PA is very obvious. There's definitely a periapical relucency associated with the tooth. Also, tooth number 4, that's tooth number 4, there is a sinus tract right here. Right here, sinus tract associated with the tooth as well. So this root canal has failed, and unfortunately, and patient has the option of trying to save it by redoing the root canal or extraction. Now let's look at tooth number 13. Remember, tooth number 13, again, tooth number 13 and 14, they were both inconclusive based on the panoramic radiograph of whether or not the root canals were okay or failed. But not when you look at the PA of these teeth. As you can see, definitely tooth number 13, the root canal has failed, large periapical relucency. Look at tooth number 14, periapical relucency here. That's a broken file right here. These are the things that you couldn't see on the patient's panoramic radiograph. And again, you can see a periapical relucency here and broken file. That is actually about a millimeter or so, which is extruded into the periapical region. Again, you could not see these details on the patient's panel. Broken file there, large periapical relucency associated with tooth number 13, periapical relucency there. Tooth number 12 is okay. All right, again, don't rely on a panel for endodontic purposes. And let's look at the final results of tooth number 31 that we just completed the root canal. So as you can see, everything went beautifully. This was a C-shaped tooth. 2 mesials, 1 distal, and look at all of this anastomosis between the mesial canals, and look at all of that beautiful anatomy in the apical area of the roots canals of this tooth. As you can see, everything went great. We went ahead and temporized the tooth, and patient's going back to his dentist to have tooth number 31 restored permanently. And I will talk to the patient about teeth number 4, number 13, and number 14, about the guarded prognosis for these teeth, especially tooth number 14. I'll make sure that I'll definitely tell the patient that broken file in the mesiobuccal root of tooth number 14, that file, we may not be able to remove it. And in trying to remove it or bypass it, that broken file can actually get pushed out even further into the periapical area. So I will make sure that I talk to the patient about that and document that in the patient's chart notes for sure. And I'll also, of course, always talk to the patient about the guarded prognosis, of course, and also about the alternative to endodontic retreatment of these teeth, which is extraction. And let the patient decide. All right, very good.